Hi, everyone. This is Brian Shapiro from CTA Pathology. Hope everyone's doing well. Today we are going to do vascular tumors. So I've put together a short PowerPoint and then we'll show some slides. So vascular tumors, this is a large area, many different entities, and the classification of these tumors is very controversial. In this talk, given the constraints of time, we're going to discuss just the more common entities and leave out some of the very rare ones. And there's a lot of controversy even in 2021 with how to classify these things. For instance, reactive versus neoplastic is even not clear. Angiolymphoid hyperplasia with eosinophilia, is this a vascular tumor or is it a pseudolymphoma? The new T-cell pseudolymphoma classification puts this tumor into a T-cell pseudolymphoma, but traditionally it's been a vascular tumor. So that's just to show you it's continually evolving. So I think a good framework for this is to divide it first into reactive lesions and then real vascular tumors. Under the reactive lesions, we're going to look at Masson's tumor, which is an unusual endothelial proliferation, often occurs in an organizing thrombus, but can arise in a pre-existing angioma. And these present as tender nodules clinically and have a specific histology, which I'll show you, and something to know about because they like it on boards and also can be mistaken for an aggressive vascular tumor if you don't know about this entity. The next in the reactive lesions is reactive angioendotheliomatosis. This is a group of reactive lesions with vascular proliferation. The one that's most interesting to know about is diffuse dermal angiomatosis, because this can be a tip-off of underlying disease such as cryoglobulinemia, antiphospholipid antibodies, or it can be a lesion above calciphylaxis. So it's something to be aware of. Reactive lesions that are interesting further are glomeruloid hemangioma, which is often seen in POEM syndrome. And so this is, as you know, polyneuropathy, organomegaly, endocrinopathy, M protein, and skin changes. And the interesting thing here is the M protein. So seeing this in a cutaneous biopsy can lead to the diagnosis. Then the next group after reactive is vascular ectasias. So this is not really a proliferation of vessels, it's just ectatic vessels. The common ones here are nevus flammeus, which is a group, the salmon patch, which is usually in young individuals and resolves with time, and the port wine stain, which persists. And then others in this group are Sturge-Weber syndrome, which everyone knows, Klippel-Trenaunay. We have this limb enlargement and dilated capillaries on pathology, angiokeratoma. Some new entities in this vascular ectasia group are cutaneous collagenous vasculopathy, where you see dilated vessels with these hyaline deposits in the walls. Others are unilateral nevoid telangiectasia, hereditary hemorrhagic telangiectasia, and venous lakes. And all these essentially present with a similar histology, which is dilated vessels without proliferation, and then have the other characteristics which allow you to subclassify these. Under the benign vascular tumors, the ones to think about are the congenital hemangiomas, and this is another board's question. The two types of congenital hemangiomas are the rapidly involuting, so-called rich, and non-involuting, so-called niche. And these are both GLUT1 negative. So there's an antibody that stains GLUT1, and these are GLUT1 negative tumors. The infantile hemangioma is GLUT1 positive. So this, again, is another board's fodder. The other benign vascular tumors I want to go through are acquired tufted hemangioma, pyogenic granuloma, cavernous hemangioma, and with this, these are associated with Maffucci syndrome, blue rubber bleb nevus, blue rubber bleb syndrome, And sinusoidal hemangiomas, those are the cavernous ones we'll discuss. Other benign vascular tumors, microvenular hemangioma, hobnail hemangioma, angiolymphoid hyperplasia with eosinophilia, targetoid hemosiderotic hemangioma, and cirrhoid, which is an arteriovenous hemangioma. So these are all the benign hemangiomas we are going to go through. Then there's an intermediate group of vascular tumors. The best known is Kaposi's. And Kaposi's, the four types are classic, endemic, age-related, or the iatrogenic type. And then clinically, as everyone knows, the patch stage, the plaque stage, the nodular stage. And these are HHV8 positive lesions. And this difficult group of hemangioendothelioma, and this is a tricky one. The only one I want to really get into is the epithelioid hemangioendothelioma. Of course, the spindle cell hemangioendothelioma has now become a spindle cell hemangioma, and it's a kind of controversial entity. So we'll discuss epithelioid hemangioendothelioma. Then we'll look at malignant vascular tumors. The most common one is angiosarcoma. This, as you know, is in the elderly, on the face and scalp most commonly, can be secondary to lymphedema and also secondary to chronic radiation. And these are bad actors, and it's important to be aware of them. Then I'll touch on this radiation-associated vascular lesion, which is associated with, as the name says, radiation, and can be a real issue as they can be extensive and difficult to manage. And lastly, we'll look at some other lesions in the chapter, which is glomus and glomangioma. So that's kind of an overview of things we're going to look at today, and hopefully you'll find this interesting. So the first lesion we're going to look at is Masson's tumor. Here we have, looks like maybe a punch biopsy. And you can see there's a relatively normal epidermis, and in the upper reticular dermis, there's a nodule with a lot of hemorrhage. When you go on higher power, you can see it's a vascular proliferation. It's comprised of small vessels, some prominent endothelial cells. And you can see this probably was a vessel which thrombosed and now has got this organization where you've got some fibrosis, some collagen. When you look at other parts, you can see there's like a papillary organization, little papillae comprised of endothelial cells associated with small vessels, fibrosis, and sometimes it merges with a thrombosis. So this is a Masson's tumor. And you can see if you just get a small biopsy of this, you could be confused and start thinking this is atypical with enlarged cells. When you get the whole picture of this dermal nodule, it's clear Masson's tumor. Here's another one. Here you can see the background vessel with thrombosis. And here you can see the areas of thrombosis merging with a papillary proliferation without fibrovascular cause. And there's some pleomorphism and some enlarged cells, but associated with a lot of erythrocytes here, but no real mitotic activity. And here the little papillae. And this is, again, something people like on board. This is Masson's tumor. The next one I want to show you is also under the reactive. And here we have a nice punch biopsy. You can see there's some parakeratosis, a little bit of acanthosis, and a kind of busy dermis. And in this busy dermis, you can see small vessels with kind of prominent endothelial cells diffusely arranged in an almost parallel fashion in the dermal collagen. There are no plasma cells, there's no mitotic activity, there's some erythrocyte extravasation. You can see these small vessels, and this is not really a tumor because you can see it's going all the way across the dermis, extending deep. And there's a little bit of sparing of the superficial dermis, and then this these small vascular proliferation all the way across. And this is diffuse dermal angiomatosis. Often, as I said, results from ischemia underlying and can be with antiphospholipid antibody, procoagulant states. But importantly, we've had a few cases where there's calciphylaxis. So when you see this in the upper dermis, this diffuse dermal angiomatosis, if there is fat in the biopsy, go down and look and make sure you don't have underlying calciphylaxis, where you'd see calcium in the vessel walls. This case did not have that, but just something to be aware of. And these often cause confusion, and people think they could be a low-grade angiosarcoma sometimes when you look at low power. But when you really go up on the vessels, they do not have much atypia. Okay, the next entity is also under the reactive, and this shows a nice shave biopsy with a dermal proliferation comprised of, looks like nests or balls of a cellular proliferation. And there's some clearing around the balls of cells. If we go up and look at this, we see this is comprised of small capillaries. And with this clearing around it, it looks like a glomerulus. So this is a glomeruloid hemangioma. I've never actually seen one in practice, but you see them at boards. And this is associated with Poem syndrome. And you can see that this big dilated vessel with a small congery of capillaries inside and the space here is reminiscent of a glomerulus. And so this is a glomeruloid hemangioma. It's a pretty distinctive histology. Now, most people with Poem syndromes they have skin lesions, but they don't have glomeruloid hemangiomas. This is kind of not the most common vascular lesion in Poem syndrome. But when you see it, it's a diagnostic. So imprint that picture. Okay, we're getting to the next group, which is now vascular ectasias. And as I said earlier, these all do not have a specific histology based on whichever one you find, whether it's a nevus flammeus or Sturge-Weber or Maffucci's. They all are essentially dilated vessels filled with erythrocytes and bland endothelial cells. This is a patient with a lot of solar damage, so obviously this would not be a salmon patch because that's in younger patients. But this is just the histology of all these hereditary telangiectatic telangiectasia or Sturge-Weber or any one of those. Okay, here's a little fun thing. This is a vascular proliferation. And I put this in because this is not skin. This is something you haven't seen. And this is neural tissue. And so this would be Sturge-Weber because this is the malformation you see in the nervous system in Sturge-Weber syndrome. The next is one people are mostly familiar with. Again, a shave biopsy with some epidermal hyperplasia and big dilated vessels in the papillary dermis, abutting the epidermis. And these are congested with erythrocytes, and there is some often thrombosis. Here you can see where there's sludging and thrombus formation. And this is an angiokeratoma. Important thing here is to know about you can get 4-dye spots and the alpha galactosidase deficiency in Fabry's disease. So important thing here is to know clinically how they're presenting and be alerted to Fabry's disease. Here's a clinical of 4-dices angiokeratomas on the scrotum, I think. And the next This one's not loading, so I'm just going to go to another clinical. This is also in the vascular ectasias. This is unilateral nevoid telangiectasia, and again, the histology here won't help as much as the clinical. And so this is a clinical of unilateral nevoid. This is hereditary hemorrhagic telangiectasia, where you find on the lip and on the cheek and nose telangiectasias. And here is on the lip a characteristic site for a venous lake. So these are all in the group of telangiectasias. And the histology, the size of the dilated vessels can vary, but the clinical is really important. And here's the venous lake. The clue would be that this mucosa is from the lip. And there's just a large dilated vein filled with erythrocytes, some thrombosis. Okay, we now are getting to the real vascular proliferations. And under the benign ones, the first were the congenital hemangiomas and the rich and the niche, the rapidly involuting and the non-involuting. And these can be very similar histologically. The non-involuting one is supposed to have more fibrosis. Obviously, the rapidly involuting ones don't usually get biopsies because they involute and they're not necessary to be in biopsy. So these are comprised of proliferation of dilated and small vessels with bland endothelium and strips of fibrosis in between. There's some variation in size of the vessels. That's supposed to be a clue for for non-involuting ones. And here you can see these are just small vessels, unremarkable, different sizes and shapes, and these dense areas of fibrosis between them. And these would be GLUT negative, important. Here's a picture of a rapidly involuting congenital hemangioma. Okay, the next one to be aware of is this, again, an important entity because it can be misdiagnosed. Here we have a punch biopsy. And at low power, this has been described as cannonballs in the dermis. And you can see why. There are these balls of blue cells in the dermis. When we go on higher power, we see these balls are comprised of small capillaries. And at the edge of some of them, there's a dilated vessel with the capillaries kind of pushing into the dilated vessel. And that's characteristic of this entity. See these dilated vessels here? Some enlarged endothelial cells, but otherwise unremarkable. No mitotic activity, no pleomorphism, no piling up of endothelial cells. You can see these balls of cells, no plasma cells, and then these dilated vessels at the edges. Here you can see it nicely. And this is an acquired tufted hemangioma. Again, benign lesion, often on the neck. This one has been scratched. There's some ulceration. And here's this characteristic picture of the ball of capillaries pushing into the dilated vessel at the edge. So acquired tufted hemangioma, I think that also used to be called angioblastoma. And the low power is really the clue on this one. Here's another one, which is not as obvious. Nice punch biopsy. And here, some balls of cells, but some cords. And you can see this might be thought of to be diffuse dermal angiomatosis. But diffuse dermal angiomatosis is just diffuse little capillaries all the way through the dermis. This has got definite areas where these are forming these nodules of capillaries. And here the dilated vessels at the edge are not as well formed. Let me see if I can find some. Maybe there's one there, and over there you can see this dilated vessel with the capillaries pushing into it. So this is an important one to know, acquired tufted hemangioma. Tufted hemangioma. Okay, the next is for the first years. This is an easy one. Rapidly growing pregnancy, often on the lip, recurs in a significant number of cases. A polypoid lesion, ulcerated, comprised of capillaries, often with neutrophils. This is the pyogenic granuloma or lobular capillary hemangioma, and we see these commonly. This can have all kinds of things. You can have extramedullary hematopoiesis. You can have, as I said, a dense neutrophilic infiltrate. And these are bland capillaries. And the architecture actually gives it away. Here's another one, which is more traumatized. Again, this polypoid lesion, these capillaries, and there's a lot of fibrin. And the differential here is polypoid granulation tissue. But you don't see the real architecture of granulation tissue with the macrophages and plasma cells and sometimes fibrosis later. So this polypoid lesion with dense capillaries here is a pyogenic granuloma. Sometimes you can find mitotic activity and other little bit of reactive change in the capillaries and the endothelial cells, but these are totally benign lesions. Okay. The next is a clinical of a cavernous hemangioma. So these are proliferation, but not of capillaries, of larger vessels with dilated big lumens. And this is a cavernous hemangioma, and yeah, you're seeing one in the fat. And this, in contrast to the things we've been seeing now, has got large dilated vessels with really thin, bland endothelial cells, some serum, and really unremarkable otherwise. And again, all that group that I showed you of cavernous hemangiomas, all the different entities, the histology is all the same. They're all just comprised of these large dilated vessels. Sometimes an irregular shape here. Here's another one which is more subtle. This you can see is an acral site. And deep in the dermis towards the panniculus, you can see these dilated vessels. And the differential here would be an ecrine angiomatous hamartoma, but you don't see the ecrine part of it. And these really big dilated vessels are cavernous vessels with the bland endothelium. You can see here little flat endothelial cells, and this is a cavernous hemangioma. Okay, the next one is an interesting lesion. This is a nice deep punch biopsy, and you can see there's a pandermal neoplasm comprised of cords of vascular spaces. You can see when you go on higher power, these little cords are comprised of vessels with endothelial cells, and they're dissecting deep down through the collagen bundles. So the differential diagnosis here would be a low-grade angiosarcoma, Kaposi sarcoma, or this microvenular hemangioma, which is what this is. Sometimes a clue is on top. You see larger vessels dilated, and all the while there are these small endothelial cells which are really unremarkable. And then deeper down you see these vessels diving through the collagen bundles, forming slit-like vessels, but no plasma cells, no atypia, none of these little pink globoid, little pink bodies that you see in Kaposi's. So this is a microvenular hemangioma, and it should not be mixed up with the Kaposi sarcoma. You can see it doesn't go into the fat here. Now, this overlaps a lot with targetoid hemosiderotic hemangioma, where the deep part looks just like this, and the top part is dilated, but there's hobnails over here, and hemosiderin deposition. So that would then put it into the targetoid hemosiderotic, but these are kind of a spectrum, both benign. Okay, we now get to another interesting entity. Here is a dermal proliferation, a big nodule comprised of vessels with prominent hobnailing of the endothelial cells. You can see here, associated with a dense infiltrate at the edges here, comprised of lymphocytes and lots of eosinophils. See them? So this is angiolymphoid hyperplasia with eosinophilia, also I think known as hobnail hemangioma. And this is the one where they now think this might be a T-cell pseudolymphoma, better classified as, because as you can see, when you get these fields, they really look like a lymphoid lesion and are not that impressive for a vascular lesion. However, when you go to the center of the lesion and you see these hobnails, that now becomes much more characteristic of a vascular lesion. So here you can see this you could think of as a T-cell pseudolymphoma, this you could think of as a hemangioma, but put it together in 2021, these of most people would classify these as the angiolymphoid hyperplasia with eosinophilia. Something that's really used often on the boards, and we see them on the face. They present as red papules, often around the ear, other sites. And here's another one, and here you can see even better the lymphoid aggregates are now forming germinal centers, where you've got the germinal center surrounded by a mantle of small lymphocytes. And this really goes as a lymphoid lesion. And the clues would be the vascular lesions with a hobnailing adjacent to it. So this is florid angiolymphoid hyperplasia with eosinophilia. Here you can see these thick-walled vessels with the hobnails. And yeah, they are actually forming germinal centers. You can see the germinal center has got these tingible body macrophages, which would stain with CD21, the dense lymphoid infiltrate, the mantle, pretty well developed. And then next to it, these vessels with hobnailing, and when you look carefully, there are eosinophils, these bilobed cells with a red cytoplasmic granule. Here we go. So another angiolymphoid. I'm just going to show a few more of these, because it's a pretty characteristic ball of cells, a ball in the dermis pushing into the panniculus here with these dilated vessels with hobnails, with lymphocytes and eosinophils. This is a perfect picture of a angiolymphoid hyperplasia. The last one, similar. Now you can see at low power you're already starting to make the diagnosis. And here is a clinical picture with multiple lesions. These were biopsied and were all angiolymphoid. And this is, as I said, a fairly characteristic site for them. Okay, we're on to the next group, which is still in the benign. And here you can see this nice punch biopsy, probably on the scalp with these hairs. And at low power, you can see it's a vascular proliferation, and here are vessels with thick walls. And then even in this low power, you can note the vessels with thin walls. So you've got two types of vessels here, arteries, which you've got this muscular wall, and veins. You've got the thin wall with the bland endothelial cells. Let's see if we can put them, that vessel and that vessel. You can see the difference. So this is an arteriovenous or cirrhoid hemangioma. We see these commonly, often on the face, on the nose. And again, it's a good boards question. And I think once you've seen a few of these, you can clearly diagnose. The clue is the two types of vessels, thick walls and thin walls. Arteriovenous cirrhoid hemangioma. Beautiful histology. And as far as I know, there's no syndrome associated with it. It's just a variant of benign hemangioma. Here's another one which is obviously harder to diagnose because it's just a shave biopsy, probably on the face with some sun damage, but you can see these large, thick-walled vessels. And here it's not so easy to find the thin-walled ones, but this is just another biopsy of an arteriovenous hemangioma. And here is the clinical of this one was on the ankle. These little blebs of dilated vessels, and biopsy showed arteriovenous. Okay, we're now moving on to the intermediate group, and these are the first one here is going to be capices. I'm going to show quite a few pictures of capices because this is something that we have to be aware of, and that is often, it can be missed. Okay, so here we have a nice shave or sulfurization with lobular vascular proliferation in the upper dermis. And at low power, it's not particularly infiltrative, and this you could start thinking of pyogenic granuloma. You could think of angiolymphoid hyperplasia with eosinophilia, and they would all be reasonable ideas here. When you go on higher power, you can see this is comprised of vessels. Some of these vessels have got slit-like spaces, and some have got these spindled cell pattern over here. Can you see these elongated nuclei with a lot of erythrocyte extravasation? And there is inflammation, there's hemosiderin deposition, and here is the clue. See the plasma cells? Eccentric nucleus, perinuclear half, purple cytoplasm. So when you see these plasma cells and you see spindle cells and they are dissecting through the dermal collagen and hemosiderin, this is not a benign hemangioma anymore. Sometimes you can find mitotic figures. This is capices, so send these cases for HHV8. Okay. Obviously, the clinical background helps if you know a patient's HIV or an elderly Mediterranean gentleman or immunocompromised, that helps. But even if you don't, often you get these, just comes in as vascular lesion because it wasn't suspected. This kind of spindling, we haven't seen in anything up till now. So if you see a vascular lesion on a low power lymphoid or inflammatory cell infiltrate, angiolymphoid is going to be in your mind, but also always capices, and go and look on high power at the nature of the infiltrate. And when you see plasma cells, then you're probably out of angiolymphoid hyperplasia. So this would be plaque stage or nodular, pretty well developed, probably nodular capices. Sometimes they're much more subtle. So this punch biopsy came in as a vascular lesion, relatively normal epidermis. And on higher power, you can see these slit-like vessels dissecting through the collagen. So the differential here would be diffuse dermal angiomatosis or microvenular hemangioma. Now, for diffuse dermal angiomatosis, you don't have these slit-like vessels. And for microvenular hemangioma, that also can dissect through the collagen bundles, but you don't have all this erythrocyte extravasation. And when you carefully look around here, you usually find some plasma cells. And then there's a thing called the promontory sign, which is the slit-like vessels proliferate around an existing vessel. See, here's an existing vessel, and here's the proliferation kind of pushing towards the existing vessel. That's here as well, the existing vessel. And this can be missed when it's subtle. It can be some of these cases have been thought to be granuloma annulare at first look. And when you go on high power, these are not histiocytes. They're forming vessels. Hemosiderin, it's always a clue. Erythrocyte extravasation, also a clue that you're dealing with a vascular proliferation. And when you start looking, this is all over the show. It's going all the way through the collagen and pushing into existing vessels. Yeah, the existing vessels. So I always keep this in my mind when you see what Sweden calls the busy dermis, Kaposi sarcoma, patch stage. Important diagnosis to make. Okay. This is the most characteristic part, these slit-like vessels with some atypia of the endothelial cells, a little hyperchromatic. That one's got a big nucleus. It's got some pleomorphism shape. And then here, the hemosiderin deposition is always a clue. Here's another one that's better developed. Again, a dermal vascular proliferation, slit-like vessels, erythrocyte extravasation, sometimes these pink bodies, which are degenerate erythrocytes. Yeah, maybe some. Hemosiderin, you can see that's a recurring theme. Some atypia and spindled endothelial cells dissecting through the collagen. And this is you can see it's just not like the other benign vascular neoplasms. It's much more aggressive. Look at these endothelial cells, which are pleomorphic, dissecting these vessels growing into the dermal collagen. Okay, you don't have to find everything on everyone. I'm looking for plasma cells here, and they certainly are not easy to find. But the erythrocyte extravasation is pretty clear here. Okay, so probably plaque stage Kaposi sarcoma. Patch stage Kaposi sarcoma. And here is an HHV8 stain. I think it's better on the... And yeah, you can see the vascular proliferation growing down into the fat here with the endothelial cells staining with HHV8. Some more over here. You can see how it's dissecting through the collagen bundles here. Okay. Important disease to know about. And here I just put a clinical, these purple plaques, fairly characteristic of Kaposi sarcoma. Okay, we now get to a kind of trickier entity, which is epithelioid hemangioendothelioma, also intermediate malignancy, usually have a good prognosis, but there have been metastasis and aggressive growth. So here we have a nice biopsy of a lesion occupying the dermis. You go on higher power, you can see it's a vascular lesion. It's making vessels. The cells the lesions comprised of cells which are epithelioid. They look like epithelium with oval nuclei, small nucleoli. And the vessels are overtaking the dermal collagen. And the clue to this diagnosis is finding intracytoplasmic vacuoles, sometimes with erythrocytes inside them. There's one there, I think. Take a look over here. Yeah, you can see there's some pleomorphism. You can see mitotic activity. You can see some hyperchromatic cells forming these poorly formed vessels. and some intracytoplasmic here, some more as well. See? And this is the hemangioendothelioma, this intermediate malignancy. And often they are well circumscribed and look just like a benign vascular lesion on low power. But again, the pleomorphism and the intracytoplasmic vacuoles are clues to the diagnosis. Here are beautiful. There's the nucleus being pushed. And I'm going to show you a few of these because it's an important diagnosis not to know about. Here's a well circumscribed one with areas of hemorrhage, with again these epithelioid cells and the intracytoplasmic vacuoles. Okay, this one's associated with the neutrophilic and eosinophilic infiltrate. And sometimes the vessels are poorly formed, and so it looks almost like a solid lesion. So, you know, epithelial neoplasm would come to mind. And the stains to do on this would be a CD31, 34, or an ERG. An ERG is a really good vascular stain. And here you can see some of these cells, I think, have intracytoplasmic vacuoles with erythrocytes. So this is an epithelioid hemangioendothelioma. They can be pretty invasive. They can have areas that are separated, you know, skip areas. And here's another one. This one you can almost think of as a sebaceous neoplasm or clear cell squamous cell carcinoma. Those all into the differential. And so this is a rare entity. It's just something to know about when you see these epithelioid neoplasms in the dermis and there's clear cell change in vacuoles. Add an ERG stain or some kind of vascular stain just to make sure you're not dealing with an epithelioid hemangioendothelioma. Here you can see some of these vacuoles are actually inside the epithelioid cells, which is, as I said, the clue. And I think this is, yeah, this is the last one. You can see these are not completely bland epithelioid cells. There's different nuclear shapes. Okay, so now we've moved through the intermediate phase and we now get to the most aggressive vascular tumors, the malignant ones, and the one I'm going to show you is an angiosarcoma. Usually old people. This is one in sun-damaged skin. And here you can see a dermal neoplasm dissecting all the way through the dermis into the fat. And the neoplasm is a vascular forming vasoformative. It's forming vascular spaces. And this is clearly malignant. Big cells, smaller ones, hyperchromatic. The nuclei have got different shapes, big nucleoli, some of them. They're mitotic figures. There's piling up in where you find the vascular areas, you find piling up of nuclei. So it's not a single layer just lining it. You can see here it's double layered, triple layered. And this is an angiosarc. Aggressive tumor. These are very hard to treat. They're very hard to clear the margins. And this is just something to be aware of. Now, be careful when there are these shaved biopsies and it's just the top, because that can really be problematic. So it's often useful to know the clinical size of the lesion. Here you see these poorly formed vessels, nothing kind of normal about these vessels. And these pleomorphic cells, here's a mitotic figure associated with inflammatory cell infiltrate. Piling up all the characteristics of an angiosarcoma, just dissecting through, overtaking the dermis. Sometimes they can be more subtle. This is a scalp biopsy and looks relatively normal. When you go on higher power, there is think this one was trickier. It had to be stained, but look in the center here. You see there's a vascular proliferation. And this turned out to be a low-grade angiosarcoma. But these can be fairly subtle when they are, early on, or not as well developed as the one I showed you before. Here's a clinical picture of one, and this was obviously associated with lymphedema, and so this is a secondary angiosarcoma to lymphedema. There's a histologic variant of angiosarcoma, epithelioid angiosarcoma. And here is a representative sample of one. You can see it's a dermal nodule comprised of pleomorphic cells with very poorly formed vessels. And these cells are very epithelioid. They look cohesive, mitotic figures, atypical nuclei jutting into the vascular spaces. And this obviously would need a workup to characterize the cells. And these epithelioid angiosarcomas are positive with both the vascular markers like ERG and with the keratin marker. So before these, you call this a carcinoma, think of a vascular marker, especially if there's some vessel formation. These are not pre-existing vessels. These are vessels made by the tumor. And you can see there's an aggressive tumor with a lot of cytologic atypia, very cellular. Here's the clinical picture of this, and you can see these are really difficult to treat. Aggressive vascular neoplasm. And yeah, I've put another one because this is an important one not to miss. Here you can see it's forming vessels, but clearly malignant cells. Infiltrative growth pattern, aggressively going. And then the more solid areas, you can see why it's called epithelioid, because they look like epithelia. Okay, then lastly, I'm just going to show a few interesting things. This is once you've seen it, you'll know it, lymphangioma circumscriptum. So this is in the vascular tumors, but it's a lymphatic, and the stain here would be D240 to stain lymphatics, and you can see the valve. So this is the differential would be angiokeratoma, but this is lymphangioma circumscriptum. Here's a clinical picture of a lymphangioma on the neck. And then this entity, I don't want to spend too much time on, but it's a big headache for dermatopathologists. Radiation site, and you get this vascular lesion, and it's comprised of thin-walled vessels dissecting through the collagen, not enough for an angiosarcoma, but not totally benign either. And these are these radiation-associated vascular lesions. RAVL, there's a long literature on them. The C-MYC, I think, is a stain that can help distinguish these from angiosarcs. These usually have to be seen at expert places because they're extensive, and the management is very tricky. I think it's still recommended to take them all out, but you can see some pleomorphism, some hyperchromatic endothelial cells that dissect through the dermal collagen. And then lastly, for the boards, is a glomus tumor, painful often on the digits. And you see these glomus cells which stain with SMA, and they've got pink cytoplasm and bland nuclei, all look the same, bland oval nuclei, and often surrounding vessels, because it's where they originate from. So this is a glomus. Once you've seen one, you should be able to diagnose it. There's a clinical of a glomus. Now the glomus, this is one might be called a glomangioma because you've got the vascular spaces and then the glomus cells. Very bland. Each cell looks the same. And this one is a glomangioma with a lot of the dilated vessels and then these glomus cells surrounding them. So that's a kind of quick go through all these vascular tumors. I hope you found it useful. Just to reiterate, the reactive lesions showed massons and reactive angioendotheliomatosis, glomeruloid hemangioma, then all these ectatic ones where the histology really doesn't help, but you have to know all these syndromes. The benign vascular tumors, which the ones with a bland histology, congenital and infantile hemangiomas, the acquired tufted, the cannonball one, the pyogenic granuloma and cavernous hemangioma, and then these fairly specific histology ones, the microvenular, the angiolymphoid, the cirrhoid, then the intermediate capices and this epithelioid hemangioendothelioma, the malignant, which is angiosarcoma, a little bit about radiation-associated vascular lesions, and then glomus, glomangioma, and lymphangioma. So I hope it's been useful for everyone, and thank you for attending.